Hello, and thank you for joining our webinar today on Women in Epilepsy, a Continuum of Care, hosted by the Epilepsy Foundation. I'm Dr. Kathleen Farrell. I'm the Vice President for Public Health and Outcomes at the Foundation, and I'm joined by our presenter today, Dr. Emma Voinescu, a neurologist and epileptologist at Brigham Women's Hospital in Boston and Assistant Professor of Neurology at Harvard Medical School. Today, we're right in the middle of Women's History Month, and we are going to be discussing important considerations for women and their health and health care with epilepsy. Particularly, we want to talk about what women should know in different phases of their life, in family planning and contraception, during pregnancy and the postpartum period after having a baby. We'll talk about seizures during these times and important things to be aware of regarding medications.
Thank you all for joining today. And I hope I'm going to share information of interest for all of you. I'm going to be mindful of the time and try to leave a significant amount of time at the end to make sure that I address some of the questions that you may personally want to ask me. I have very few disclosures. Let me figure out how to advance my slides. I'm focusing both my clinical and research efforts on improving the care of women with epilepsy, and I'm also volunteering my time and working with organizations like the Epilepsy Foundation and My Epilepsy Story along the same lines, trying to educate and to empower women with epilepsy. And today I'm going to focus on the reproductive age, and I'm saying women just because that's how we are used to talk, but it's really all females of reproductive potential. And I'm going to discuss a little bit about the period before pregnancy, about pregnancy and the postpartum, just because that's my area of expertise. I think there's a time to personalize care at each biological stage, and you should definitely talk with your neurologist about that. And this is an area where a time of our life where more research has been done, because epilepsy and medication may have an impact not only on the mother, but also on the children. But there's definitely ongoing efforts to advance our knowledge to really comprise all ages and the entire lifespan. There's definitely a lot of research going in pediatric epilepsy, and we are extending more and more into menopause and beyond. But my focus today is going to be pregnancy and the time around pregnancy. I have to say that it's ideal to start the process before considering pregnancy. You really want to know your epilepsy. I think it's sad when in clinic, when I talk with a patient, I feel like I know more about their epilepsy than they do. You should really know your epilepsy. Make sure you ask the questions from your doctors and understand what type of epilepsy you have. Is it a focal type of epilepsy, or is it a generalized type of epilepsy? What type of seizures do you have? Do you have one type of seizure, two types of seizures? Have you thought of how you would bucket your seizures? If you were to think of all the seizures you've had in your life, how many types would you say there are? It's useful to know your type of epilepsy and your type of seizures, because when you're thinking of pregnancy, you'll see the balance between risks and medications is different based on your epilepsy and your type of seizures. And maybe you're not ready for pregnancy, or maybe you're ready, but you have not discussed it with your doctor. Please make sure that you have a solid contraception in place. That will give you time to plan for everything and to really feel good about how your epilepsy is controlled and about the plan that you have going into epilepsy. And talking about contraception, there's a large variety of contraceptives out there. And what I want you to know is that there may be interactions between the anti-seizure medications you're taking and the hormonal-based contraception. And this is just a simplified way of looking at things. You can see medications here in green. These are medications that don't interact with hormonal contraception, and therefore, if you're a woman on one of these medications here in the green category, you don't need to worry. You can really choose anything that's out there. On the contrary, if you're on one of these medications here in the red category, you have fewer birth control options. And IUD, as you see, an intrauterine device, is an option for everyone, and it's a great option. But just know, for those of you who prefer oral contraceptive pills, that those are an option for many of you. So the yellow category here is in yellow because it's really not an all contraceptive appropriate situation, but you're also not restricted to just a couple of choices. You have more choices, but you need to discuss in detail about the interactions, which can go both directions. Your medications can affect the efficacy of your contraception, but also contraception may affect the levels of your medications and may trigger breakthrough seizures. And there's a solution for that. It doesn't mean that you cannot use those contraceptives, but you should talk to your doctor and have that knowledge and be aware that you may need to follow with your doctors a little more closely after you start a hormonal contraception if you are on one of these medications in the yellow category. And it may be your gynecologist, it may be your neurologist, and I would say that if you feel that you're not getting a clear answer, you may consider seeing an epilepsy specialist. I think it is important for you to be on the right contraception, for you to really be able to plan for your pregnancy, because so many pregnancies are unplanned. And there's this false belief that perhaps epilepsy affects your fertility. And is that true? I would say that the best, most solid study we have is this so-called WIPOD study that involved 3 centers and Brigham, and Dr. Pennell, more senior doctor, who's one of the experts that I trained with, and she's my research mentor as well, was one of the leading PI of the study. They looked at fertility in women with epilepsy, and they compared with women without epilepsy. And you can see here the numbers of the women without epilepsy that they enrolled in this study. And these are the women with epilepsy, as expected, and we'll talk about this later. Lamotrigine and levetiracetam, which are some of the most popular medications, were the most popular amongst the women enrolled in this study as well. And what they found is that really there's not much of a difference between women with epilepsy and women without epilepsy. The ovulation rates were similar. The time to get pregnant was surprisingly similar. The live birth rates were similar. So in other words, your chances of getting pregnant is the same as everyone else, regardless of your medication. So do remember that you do want to be on the right contraception for you, and plan for that pregnancy, because planning is key for a healthy you and for a healthy future child. And that discussion with your doctor is really important because epilepsy is so heterogeneous. We have so many medications, fortunately. Unfortunately, we don't know as much about all our medications, and I'll talk about that. But medications risks are different, and epilepsy, as I said, is heterogeneous, and some of you may have predominantly auras, or what we call focal aware seizures, that are small seizures in one area of your brain that doesn't lead to any impaired awareness. They may be, disturbing because they're not under your control, but are those posing a risk for the baby? That's a little more debatable, but we are all in agreement that big convulsive seizures, what people call grand mal seizures, are definitely detrimental and life-threatening for both the mother and the child. Letting epilepsy untreated is not an option, and the risk of problems come up if you were to do so. So you do need to talk. This is a very personalized balance for each of you. And you need to go through each of these risks of the medications, of the seizures, and of attempting to optimize your regimen prior to pregnancy. So I'm going to start with the risk of medications to start with. What are the things we are thinking about when selecting medications for our patients? On one hand, we want you to have a healthy baby without birth defects. So birth defects is the first thing that comes on mind. But then we also don't want to affect how smart your baby will be. We want you to have a healthy, beautiful baby and a smart baby, because learning disabilities may equally affect the quality of your child's life. We also want to know how metabolism of your medication changes during pregnancy and make sure that we keep you safe, with seizures, as we were talking, and I'll talk a little more about that later, are detrimental. So sort of keeping an eye on you during pregnancies is something that I do a lot for my pregnant patients, and making sure that their medication doses is appropriate for their pregnancy. And then what about breastfeeding? There is such controversial opinions about it, but I think I hope I'll convince you that the data we have been accumulating throughout the years point to the fact that breastfeeding is safe with most of our medications. So that's something that's more of a personal decision, but a lot of the times you should not factor in that you are on an anti-seizure medication. So starting with birth defects, I'm going to go through all this information, and I feel like I should take a break and remind myself and you that we're really talking about this for you to have the knowledge, be empowered, ask the right questions, and really optimize your care. But really, the majority of women with epilepsy have healthy, smart babies with no birth defects. So remember that. We are now going to talk about birth defects that a few percent of children experience, and really the majority are healthy without birth defects and without any sort of exposure. 1 to 3 out of 100 children will be born with what we call a major congenital malformation. Those are birth defects that require surgeries shortly after birth, and that affect the quality of life of your child going forward. So those major birth defects is what I'm going to talk about, not what we call minor anomalies. Many of us may have those. So those are not part of this discussion. So just remember, before I move forward, that even without any medication exposure, there is a chance that your baby will have a major birth defect. And really, 2 to 3 out of 100 babies will have that, regardless of exposure. And that number may be higher if there's a family history of birth defects on the mother or on the father's side. And you want to think about that. You want to think about whether your medication increases the risk of birth defects before you become pregnant, because by the time you're seeing your doctor in clinic after a positive pregnancy test, it may be too late to reverse anything. The body structures are formed within the first trimester. For the majority of the birth defects, we really cannot reverse things past the first trimester. That's why it's so important to really think about your medications beforehand. And fortunately, we do have very detailed ultrasounds that obstetricians can do and sort of keep an eye and inform you on any abnormal finding. But some of the birth defects happen a few days after you miss your menstrual period, so really early in pregnancy. So do talk about the impact of your medications for birth defects before you get pregnant, if you can. And how do we know that our medications increase the risk of birth defects? As I was telling you, there is a significant risk out there without any medication exposure. We think that overall, it was noticed that women with epilepsy, their children are at twice as many birth defects. So the risk is about twice higher. About 7% of women with epilepsy on anti-seizure medications will have a baby with a major congenital malformation. And throughout the years, it became absolutely clear, one, that it's not the epilepsy increasing the risk of birth defects, and second, that not all our medications are equal. Some are definitely carrying higher risks than others, and others is really questionable if they carry any risk at all. And we have a bunch of pregnancy registries that are collecting this type of information throughout the world. The largest ones are the North American Anti-Epileptic Drug Pregnancy Registry, which collects data from US and Canada. It's actually based here in Boston. The other one is called URAP. It's based in Europe, but it's really more of an international registry, collecting data from Europe, Asia, Australia. So some of the smaller registries report to this big pregnancy registry. Going back to the North American Pregnancy Registry, if you Google aedpregnancyregistry.org and you get to their webpage, you can see what's the latest data yourself by clicking here. This is the number to call, by the way, if you're pregnant and you want to contribute with your information, because this is how we know these things, because women like you participated in these registries and helped others select the right medication. And here is the latest data. They usually update the information in the fall of each year. So this is data from October 2021. That's when it was updated. And you can see that the number here at the bottom is the rate of congenital malformation in their control. It's 1.7. So in other words, close to 2 out of 100 babies are born with a major congenital malformation without any exposure. And these are patients that were on one medication only. So patients on lamotrigine and levetiracetam, you see that those are a lot of them that reported outcomes here, have a prevalence of these birth defects of 1.9%. So both of these medications seem to have similar numbers. And because there's a lot of women that reported outcomes to this pregnancy registry, we are quite confident that the risk is not much higher than that. There are other medications that seem excellent, like lacosamide. Some of you may know this as Vimpat. But there's only 64 women that reported outcomes. Out of those 64, encouragingly, none of them had a child with malformations. But as you can see, our confidence is not that great. So the higher the number, the more likely that this information is accurate. The lower the number, time will tell. Most likely, all the numbers, if this is a safe medication, will be closer to 1.7, which is the risk in the general population. But this is a good overview of what is the risk associated with one medication. And sort of historically, these registries have reported that the risk of being on more medication is a little higher than the risk of being on one medication. So if you can be on one medication, that's the preferred situation. But as we know, some epilepsies don't respond to one medication only, and you may need to be on 2 or more medications. In those circumstances, medications that seem to have a higher risk to begin with, and I didn't point to those, but look here, valproate, for example, has a risk of close to 10%. Topiramate also has a slightly higher risk. You can see here close to 5%. If you can avoid having in the combination of your medications one of those, that's preferable. And then medications that seem to be safe, for example, levetiracetam and lamotrigine, there's emerging data that the combination of those two is likely safe. So it's going to take a while until we'll tease apart the risk of combinations. What we know and what we are a little more confident about is the risk of individual medications. So being on less medication, on a smaller number of medication is a good thing. If you can think about it, talk to your doctor and see whether you really became perhaps seizure-free after the third medication was added. Can you perhaps remove the first one that was there? Prior to pregnancy would be the time to ask that question and have a discussion about it. Your doctor would know better if you would tolerate having any of your medications removed. And then if you are on one medication, can you be on a lower dose? The European-based registries show that even for lamotrigine, a medication that I told you is one of the safest, being on a lower dose was associated with a lower risk of malformations than being on a higher dose. And I would take these numbers with a grain of salt, because There's some individual variability in how you metabolize this medication. So I wouldn't focus on the numbers. I would just take away the message that a higher dose, a higher concentration in your blood may be associated with a higher risk. And sometimes your seizures are at the beginning, it's unclear what dose will work for you. And maybe your physician opted for a medium-high dose. But if you've done well for many years, it's maybe worth asking if you can have the dose reduced. It's not worth doing so if your seizures are likely to break through on a lower dose. So again, it's a very personalized discussion. So please talk to your doctor and don't reduce the medication dose without doing so. Another information that these registries are gathering are on the size of the baby, what's called small for gestational age. And you can see here that amongst unexposed babies, about 5 out of 100 babies will be small size, smaller than what's expected. For babies exposed to medications like topiramate, phenobarbital, and even zonisamide, that number is higher. It's twofold higher or more. And some of our other medications may increase that risk a little less so than these medications here. What that means, it's still debatable, maybe an indication that they are at a high risk of complications around birth or later in life, but not true for all these babies that are small for gestational age. It's just another information that these registries provide to us and may shed some light in terms of how these medications affect the development of your babies. But as I said, we want to optimize your medication regimen such that you have healthy babies without birth defects, but also smart babies, as smart as they can be, and that our prescriptions don't affect what we call neurodevelopment, how your baby's brain is developing, and doesn't make your baby more likely to have learning disability in the future. And this is harder information to gather because it requires really dedicated researchers to convince mothers to bring the children in for this thorough, what are called neuropsychological evaluations, where all functions of their cognition are tested, where they're assessed for any behavioral problems. And they do so over the years. Most studies start at around 2-3 years of age and continue until 6 or later, because you really want to know if you notice perhaps a change from the expected normal, if that is something that the child will outgrow or if it's something that's persistent. And one of the largest studies we have is called the Neurodevelopmental effect of anti-epileptic drugs. It started quite a while ago, and it looked at children exposed to 4 of the most popular medications at that time: carbamazepine, lamotrigine, dilantin or phenytoin, and valproate or Depakote. And as I was telling you, they assessed these children throughout several years up to age 6. And comparing the outcomes, and you can see that there were a significant number of children that were exposed to lamotrigine, 100 of them, and all categories had at least 50. Children exposed to carbamazepine, lamotrigine, and phenytoin had the expected mean IQ and cognitive performance, but those exposed to Depakote had a reduction in their IQ by 10 points. They definitely consistently perform worse than children exposed to any of the other 3 medications. And then they look to see whether the dose matter. Remember how I was telling you that in terms of birth defect, being on a lower dose may be better than being on a higher dose. So, and that was true even for medications like lamotrigine. What about in terms of neurodevelopment of the baby, what's called baby's IQ? The baby's IQ is here on the y-axis. You can see that the dose of lamotrigine is here on the x-axis. So you can see that as you go towards the right, the dose of lamotrigine is increased. but really the intelligence of the baby seems to be about the same. The line shows you the trend. So in other words, neither carbamazepine, lamotrigine, or phenytoin seem to affect the baby's intelligence, but Depakote did. So not only that it overall lowered the IQ by 10 points, but it did so more at higher doses. Then there was a UK-based group, actually Liverpool, Manchester Neurodevelopmental group, that introduced a control group, children unexposed, and similarly, they showed that Depakote affected the IQ, and you can see that this is the mean IQ for unexposed children, and the green line is for the low dose Depakote. The red line is for higher dose Depakote. So Depakote is really, or valproic acid is a medication to be avoided in women of childbearing age, because it, as you remember perhaps from the table before, there's a high risk of birth defects, and the neurodevelopmental outcomes are concerning. The question that may come from looking at this graph would be, is there a dose of Depakote that's small enough that won't really significantly affect the IQ of the baby? And the answer is no, because Depakote, or valproic acid, also increases the risk of autism. So it definitely affects neurodevelopment in many ways, and if possible, better to be off it. And it may not be feasible for all of you, but have that discussion with your doctor if you are on Depakote. What do we know about the other medications? The same UK-based group that I mentioned earlier looked at levetiracetam, or Keppra, topiramate, gabapentin, and they seem to suggest that compared to Depakote, there were really no red flags, and compared to unexposed children, there were no significant differences. So Keppra, levetiracetam, there are only 42 children that they looked at here, seemed safe. We have even lower numbers on topiramate. So more needs to be gathered on these medications. And there are really so many medications that we are using these days, and there are none of these investigations available for us to know what is the impact on neurodevelopment. There is a continuation of the study that I mentioned earlier. It was called NEED, and this one is MONEED. It includes maternal outcomes, but they really continue the hard work at looking at what is the impact of our anti-seizure medication on what we call neurodevelopment, how smart your baby will be. And these are the most, this is sort of the breakdown of the medications used by the women in the study because of their known safety. As you see, lamotrigine and levetiracetam are still taking a big chunk of the subject. So we'll know even more about lamotrigine and levetiracetam, and we may know more details, which is exciting. But we won't learn as much as I wish on other medications, but we will have more than nothing. So we will have more information about zonisamide, oxcarbazepine. We'll have a few more children exposed to topiramate and a few exposed to lacosamide. So there's more to come from this study, and I hope it will teach us which medications are safer from a cognitive perspective. And this, I have to say, this is my preferred order. So this is how I put together what we discussed so far. If we are to think and combine the risk of birth defects and the neurodevelopmental problems that some of these medications may bring, my go-to medications are lamotrigine and levetiracetam, because we have solid numbers showing us that the risk for birth defect is low. And we also have neurodevelopmental studies showing us that these medications are likely safe. I almost never prescribe valproic acid. I try to do my best to replace it when I can, because that is a medication that has been repeatedly shown to have a high risk of birth defects, to reduce the baby's IQ, and really possibly trigger autism in these children exposed to valproic acid. The rest are in the middle, and I would say that carbamazepine has a slightly higher risk of birth defects, but on the other hand, was shown by the NEED study that I showed you earlier to be a safe medication for neurodevelopment. Oxcarbazepine, we have less data on neurodevelopment, but we know that in terms of birth defects, it's really as good as lamotrigine and levetiracetam. And similarly, zonisamide has a very low rate of birth defects, has a slightly higher rate of small for gestational age, and we don't know that much about neurodevelopment yet. So as more research studies are published, this preferred order may change. So in a few months, I may reorganize these, but so far, based on what we know, if I see a woman with new onset epilepsy of childbearing age, this is the order in which I would select the medications. What else can we do to improve the outcomes? So talking about birth defects, folic acid, there's more of it in the prenatal vitamins, and that's because it was shown to reduce the risk of birth defects, in particular of what's called neural tube defect, incomplete formation of the spine, spina bifida, and cardiovascular abnormalities. So that was shown in the general population. That's why the prenatal vitamins have more folic acid to begin with. Yet to women with epilepsy on anti-seizure medication, I recommend taking extra folic acid. And the reason to do so is because the same NEAT study that I mentioned earlier that looked at neurodevelopmental effects of those 4 popular medications at that time when it was started, looked at what's the impact of folic acid supplementation. And this is the IQ here of children that were coming from mothers that were taking folic acid, and these are the solid lines, versus the ones that were not taking folic acid, and these are the dotted lines. And you can see that the dotted lines for all medications combined, but also, the pairs for each medication, the dotted line lags behind the solid line. In other words, the solid line would fall somewhere at a higher IQ than the dotted line. What this means is that by taking folic acid, you may add a few points to the IQ of your future child. So the way I put it for my patients is a small price to pay to have a smarter baby. And then there's another study that came out that showed that even the risk of autistic traits is lower. And that was true for the general population. So the risk was about 1.7-fold higher for children from mothers that were not taking folic acid to have autistic traits compared to those that were taking folic acid. So about a 2-fold risk for the general population and for women with epilepsy without anti-seizure medication exposure, so those that were off medications, which were fewer than the ones on medications. But the ones on medications, that gap was 5 to 7-fold. So do remember that folic acid supplementation may reduce the risk of autism as well. The exact dose, that's not a study that was done, so we don't know how much to recommend. In general, it's 1 to 4 milligram extra. And I would go ahead and take at least 1 milligram of folic acid in addition to your prenatal vitamins. I think there's now more studies showing benefits than not. So what about your medication metabolism? There are so many changes that your body goes through, and this is a busy slide. I'm not going to go through it in detail. But what I want to point out is that your body expands, your blood flow is enhanced, and the blood flow through the kidneys is higher. The rate of filtering the medication through the kidney is higher. And at the same time, your hepatic enzymes, because of the rising sex hormones, chew up the medication faster. So the majority of medications that you're taking are either excreted through the kidneys or metabolized through the liver, or a combination of the two. And these processes are faster in pregnancy. In other words, it's as if you are on a lower dose, because that medication will be chewed up faster, will be eliminated faster. And if you look, for scientific studies on the topic, you'll see the word clearance, which is really the ratio between the daily dose and the concentration of the medication in your blood. So to think about it, what I was saying is that the clearance, so this fraction is going up. The medication is eliminated, is cleared faster from your body. So to maintain the same concentration, you really need to increase the dose. Or think about it, if this fraction is going up, if you keep the same dose, then the concentration is likely to fall down. And this is what many studies, including some of mine, have shown. So the most popular medications are here in green. Lamotrigine is this one. And the rate of elimination goes up throughout the pregnancy steadily, with the highest rate of elimination being in the 3rd trimester. Levetiracetam or Keppra increases the most in the 1st trimester, but stays higher than prior to pregnancy throughout. And there's changes in topiramate and oxcarbazepine as well that are significantly different from the baseline, which is this one line here. Carbamazepine or Tegretol is one medication where, although it seems that it fluctuates here a little bit, it doesn't change as much. In other words, for most of the medications that we prescribe, we should keep an eye on the serum concentration because the rate of elimination goes up for many of them. So if we were to plot the concentration, the levels of your medications during pregnancy, it would be the reverse. The levels will trend down. And we need to keep an eye on that because we know that if the levels drop by more than 35% of the preconception concentration, then the risk of seizure goes up. And that seems common sense when you know that if you miss a dose, you're more likely to have a seizure. And it's even if you're not missing a dose, because in pregnancy, the medication is eliminated so much more rapidly, you're at a higher risk of having a seizure breakthrough if you don't keep an eye on your levels to have the doctor suggest the doses for you. And because of all these changes that we were talking about, it's better to take medications not once daily, but twice daily, and sometimes even more than twice daily if you're on high doses of medications. And it's better to be, and I know that some insurance companies don't like that, and it's more of a fight recently, but it's better to be on extended release formulations if you can, because that will help maintain those concentrations in the blood, those levels, a little more evenly than the ups and downs that are there to begin with, and the pregnancy aggravates more. And if you're well controlled, you may not need to see your neurologist every month, but remember these and ask perhaps for your OBGYN's help. They can order those levels and you can diligently keep an eye on them and inform your neurologist if the levels are trending down for them to make those adjustments and keep you and your baby safe. So what about seizures? As I said, all those clearance changes may trigger seizures. Is pregnancy in its own? Are all the hormonal changes triggering seizures? The MONIT study that I mentioned earlier has been instrumental again in helping us understand what's the risk, because in the past, other studies did not have a control group. So what they've done, they took pregnant women with epilepsy, they monitored them throughout pregnancy and for 9 months after delivery. And they compared the seizure frequency in this pregnancy plus 6 weeks after delivery, which, as you may know, because of the sleep deprivation, all the emotional and physical stressors that you go through, may be a time of seizure worsening. So they compared the seizure frequency during this, what they call Epoch 1, to the rest of the interval that they monitored these women for. And they did the same for non-pregnant women with epilepsy that were followed, that were matched to be similar to these pregnant women here, and were followed through the same time span, and the same time periods were compared. Guess what? There was really not much of a difference between pregnant women and control in terms of those that had no change in their seizure frequency, those that had an increase in their seizure frequency, and those that had a decrease in their seizure frequency. And the seizures that they looked for here are those that impact patient's awareness. So those would be the ones where even if you don't have loss of consciousness, your awareness is not fully there. And they did include those where it went all the way to loss of consciousness, what people call grand mal seizures. So they excluded what we call auras or focal aware seizures, but all the other seizures were included in this analysis. So these are the dangerous seizures, the ones that lead to you being confused or losing consciousness, the ones that may lead to falls, the ones that would put you at risk and the baby at risk of accidents. And they show that really pregnancy doesn't seem to increase the risk of seizure worsening. When you look at pregnant women and non-pregnant women, the risks are the same. But they also showed that pregnant women are more likely to have their medication adjusted compared to those that were not pregnant. This is going back to what we were talking about, to really keep your seizure risk constant throughout your pregnancy. You really need to have your medication levels monitored and your dose adjusted, because if you don't compensate for those pregnancy-related changes in the rate at which your medication is eliminated, then the risk of seizure is up. And, I'm not going to go through everything here because I'm mindful that we are getting close to the end of my talk and I want to spare some time for your questions. But I would say that the most important risk factor that comes up in this study and in others is that the seizure frequency in the 9 months prior to conception is a very good indicator for how you will do during pregnancy. Breastfeeding, I was telling you, is safe. If you think about it, during pregnancy, the concentration in your baby's blood is similar to the concentration of the medication in your blood. After delivery, it goes down. Remember here, the line is at 1, what's 100%. So it's 100% exposure for your baby. It goes down to most of medications are in the 20-30% range. Zonisamide is a little higher, but still about 40%. Lamotrigine has more of a variation, but overall about 30%. And medications like levetiracetam or oxcarbazepine are undetectable in the breastfed infant's blood. So in other words, not only that some of these medications are safe, as I was telling you earlier, and what is important is the risk on neurodevelopment at this point. We don't care about birth defects. We only care about how these medications may impact your baby's cognitive abilities and their health. But these are overall safe medications, and the exposure is less through breast milk. And the NEED study showed that actually breastfed kids had a 4 IQ point higher, even for medications like valproic acid that I was telling you earlier that lowers the baby's IQ. Breastfeeding ramped up the IQ, even when the exposure was Depakote. So if you don't change the medication from when you're pregnant to when you're breastfeeding, the exposure is lower. It's most likely that breastfeeding is going to be beneficial for neurodevelopment. Don't factor in it's a very personal decision, but don't factor in the fact that you are on an anti-seizure medication when you decide to breastfeed or not. These are some recommendations. We work closely with the OB doctors here, maternal fetal medicine specialists, and we are fortunate to collaborate a lot. They're helping us with keeping an eye on the medication concentrations, and they're sharing with us the concern for our women and making these recommendations, similarly to the pediatricians. But there's a few more things to consider when you are postpartum. Make sure that you take good care of yourself, that you try to find a plan that works for you and your family, and you get enough sleep, because sleep deprivation is a risk, increases the risk for seizures, as you know, in many epilepsies. Make sure that you reach out for help if you have signs of depression. Depression is not uncommon at all in women after delivery, and you should ask for help if that's the case. Especially remember that some of our medications may potentiate the risk for depression. And it takes a village to raise a child. Get all the help you can get when you are at that point. And I don't like to go through this slide. I purposefully left it for the very end, but seizures are not good for you. They're not good for your children. Really, there are no good studies for me to cite and to give you percentages as I did before, because the studies that are there are reports of how detrimental seizures are. And it would be unethical to let women seize for me to be able to have solid information for you. But we know that the same way as seizures can reduce the oxygen in your blood and can change the electrolytes and the pH of your blood, it can do so for the baby when you're pregnant. And that may affect long-term the health of your baby. And the more seizures you have, the more likely your baby is going to have what's called developmental delays. Going back to what we were talking about, neurodevelopment, there's a study that showed that the IQ of the child drops if it was exposed to more than 5 seizures in pregnancies. And these are what's called grand mal seizures. We know less about other type of seizures, like what we call focal seizures. We worry a lot about those that lead to confusion because may lead to accidents, and accidents are dangerous for you and your child. And there's studies showing that even focal seizures can lead to a higher rate of small for gestational age preterm delivery. SUDEP may go up in pregnancy, especially if you don't keep an eye on your medication, and the risk for seizure goes up. But overall, the majority of women with epilepsy on anti-seizure medication have healthy, beautiful, smart babies. And it's riskier to have seizures than to stay on medication in the majority of cases. So thank you for listening. And Kathleen, I'm waiting to hear what questions are raised so far.
Yes, there have been a lot of questions coming in through our Q&A, and I'd encourage anyone to add any additional, but we'll just start from the top. Someone wonders, Emma, whether women with epilepsy who are on epilepsy medications should consider getting any prenatal genetic testing or diagnosis, like a NIPT test or something else.
It's a very good question. And I would say that we are not well equipped to act on all the findings we have from those genetic testing. So it's not commonly done, but especially if there's a family history of epilepsy, if there's concern for a syndrome, I would go ahead and do it. The studies that looked at the risk of a child sort of inheriting epilepsy, and this is a question I get a lot from my patients, really shows that there's not a much higher risk for children of women with epilepsy than women in general to have epilepsy, but it is a little higher. It's about 5% of children of women with epilepsy will have epilepsy.
Thank you. Another question is around behavioral or attention disorders that you see in childhood, whether that could be related to a maternal exposure of anti-seizure medications.
That's a great question too. And I think it's understudied in a way. I think there's, other than these neurodevelopmental studies that show that some of our medications may have behavioral problems associated with them. We really don't know. So there's so many other factors that may contribute. It's hard to blame the medication if you don't gather a large enough group of children exposed to that medication to know for sure. Behavioral problems have been clearly associated with Epicon. But for some of the other medications that I mentioned, like lamotrigine, oxcarbazepine, carbamazepine, phenytoin, I have not seen behavioral problems reported. But we have just a handful of medications that we have adequate neuropsychological evaluations for. So we have more to learn. The answer is we can't know for sure if it's the medication or something else, if there is not a good study on that medication with more children to know for sure.
Right. Another question around, can you just clarify when you spoke about inducers and non-inducers, characteristics of medication, do non-inducers mean it will be harder to get pregnant?
It's a good question that refers to the induction of hepatic metabolism and the induction of, in particular, sex hormone metabolism. So if it's an inducing medication, it's most likely to affect the sex hormone levels of contraception. Whether it's enough to affect pregnancy, we don't think so. But I think we know that the rising sex hormones in pregnancy may affect the medication metabolism, as I was showing you through the clearance studies. So that's just sort of a very rough characterization of our medications to show how they interact, in particular with hormonal-based contraception. It doesn't offer any implication on fertility or medications changes during pregnancy. That's more related to the medication metabolism per se and how sex hormones rising during pregnancy may affect those medications.
Great. A question around valproate. You really highlighted the risks with that medication. Someone who has taken it previously, do they need to be worried about it remaining in small quantities in their body? Is the damage done if they discontinue it, or is there any guidance about residual effects?
I don't think so. I don't think you need to worry about it. As long as you're not taking it during pregnancy, if you took it before, it should not affect your baby. I think there is some concern that Depakote may be associated with what's called PCOS, polycystic ovarian syndrome. Some of the studies show that that's reversible once you stop Depakote, but definitely it won't affect your child if you were on Depakote previously.
Great. 2 questions about folic acid in terms of how much first you recommend. And then if someone has been on folic acid for years and they're not currently planning more pregnancies, can they safely discontinue it?
I think so. If you're not planning to expand your family more, then you can stop folic acid. We recommend it to all women who are planning to expand their family. And those who are not planning, let me put it that way, but are not on contraception, and it may still happen. But otherwise, we recommend it to those who plan for pregnancy for the reasons I described in my presentation. And as I mentioned then, we really don't have a good study comparing doses of folic acid. As I was saying, there's more of it in prenatal vitamins than in multivitamins. Is that enough? It may be enough, but we want women with epilepsy for the reasons I was showing you to be on a little more. And how much is too much? I don't think we know. Just to put things in perspective, here in US, we have 1 milligram tablets folic acid, and those are the most commonly prescribed by neurologists. In Canada, Europe, they have 5 milligram folic acid tablets. So I would say somewhere from 1 to 4 is what neurologists prescribe here in US. I tend to be on the lower side. I usually prescribe 1 milligram extra because most of the medications I'm using, I'm trying my best to select them safely. If it's a medication that has a higher rate of major congenital malformation, higher risks associated with it, let's say you're on Depakote, then I may go all the way to 4. Or if it's a medication like Tegretol, I may choose a 2. But really for levetiracetam, lamotrigine, oxcarbazepine, zonisamide, I usually recommend 1 milligram of folic acid. And again, this is just experience-based rather than evidence-based. This is my way of practicing, by no means a recipe.
And just another question in that same vein came through. Someone who is young and 14, looking for the right medication at this point in their journey, is there an age where it's too young to consider starting taking folic acid, or no risk to start?
No, it's a B vitamin. No risk to start taking supplementation.
Great.
Usually very well tolerated. I don't hear about side effects from my patients.
Great. Question about seizures that started solely in the postpartum phase. Would you expect that those go away, or can they translate into a longer journey with epilepsy?
It's a good question. And I'm not sure about what the circumstance is, but I would definitely stay on medication, have a discussion with your doctor whether those were what's called eclampsia and more sort of pregnancy-related seizures versus true epilepsy. And I think you may need more investigations. It is also a time when sex hormone changes may influence how irritable your brain is, and you may be more prone to having seizures. For that reason, there is about a third of women who have their seizures influenced by sex hormone fluctuations. And you may have heard of catamenial epilepsy, where women are more likely to have seizures in certain phases of their menstrual ovarian cycle. And the same at around pregnancy. After pregnancy, some women may be at higher risk of seizure worsening than others. Overall, as you saw, really compared to women who are not pregnant, women who are pregnant with epilepsy have similar risks for seizures. So someone who starts having seizures in postpartum phase, I think that's more of a discussion and requires more investigations to understand if that is a new diagnosis of epilepsy, which may very well be, and maybe that you need to stay on medication long term.
Great. I know we are at the top of the hour, so I'll go through the last two kind of quickly before we start to wrap up. A question about whether cognitive or intellectual disabilities in the baby is more due to a direct impact of a medication on the fetus, or is it an indirect impact from impact in the mother? I'm not sure if I translated that question well.
I think I may understand where the question comes from. There are definitely children that are exposed to Defects and don't have autism, and children who are exposed and have autism. So I think there's both a genetic component and medications contributing to those outcomes. But it is not something that the mother should take any blame for. And, it's not something that science is advanced enough for us to understand what to look for and to advise women appropriately. Because, it may be that Defects is okay for some women and not for others. Overall, it seems that it affects a large percentage. So better to stay off it until we have more of an understanding.
Great. And final question about, you spoke about catamenial epilepsy, medications like lamotrigine or others. Do the levels change? Is it the medication level changing through the menstrual cycle in someone that's not pregnant, or another mechanism being the reason you see increased seizures during the menstrual period in catamenial epilepsy?
That's a very good question. We think it's more likely the hormonal fluctuations. And the sort of very simplified version is that estrogen is the bad guy, progesterone is the good guy. Those changes throughout the menstrual cycle that are one than the other may lead to seizure worsening at certain times in the cycle. But we know from the pregnancy data that those may affect the medication metabolism. Those changes may not be significant enough to really affect the levels. We do know that for some hormonal contraceptions in the week of break, in the placebo week, the levels of lamotrigine may vary for some women. So if you have that concern, it may be worth checking your levels at different times of the menstrual cycle to know for sure whether it's a fluctuation in your level or not. But in general, we think that the menstrual related changes are not enough to trigger a significant difference. If you are on contraception, though, it may.
Thank you. Well, thank you for all the excellent questions that were coming through. Thank you, Dr. Voinescu, for your excellent presentation and for everyone's interest in this topic and your engagement today. It's been a great session, and we were recording this session and we'll make it available within the next week or two on EF's social media and YouTube channels. I wanted to share, before we wrap up, just a few additional resources and opportunities that participants today can consider. First, if you or a loved one haven't already, please please consider taking seizure first aid training for free with the Epilepsy Foundation. Courses are available on demand at learn.epilepsy.com, meaning you can complete any course of interest, whether it's the readiness course, which only takes about 30 minutes, or the full 2-year certification, which takes about an hour and a half, at a time that works for you and you can become certified. Having as many people in the community seizure first aid certified works us towards creating a safer environment for people with epilepsy. Secondly, the Epilepsy Foundation is hosting its inaugural Epicon convention in Nashville, Tennessee on May 13th through the 15th. Epicon will unite people living with epilepsy and their families, the medical community, along with our dedicated community partners. It will be an interactive event where those impacted by epilepsy can learn, connect, and build community. We hope to see you there, and you can learn more at epilepsy.com/epicon. And lastly, if you are a loved one with epilepsy or interested in tracking your journey with epilepsy and getting personalized resources and information, please consider enrolling in Eden, which is the Epilepsy Foundation's Epilepsy Digital Experience Navigator. Among other capabilities, Eden will allow you to track your seizures, sync your medical records, and connect devices like Fitbit and others. You can enroll today and learn more at epilepsy.com/Eden. With that, I will say thank you again to everyone for joining us today. Have a wonderful rest of your day and week. Take care.
Thank you for inviting me. Thank you everyone for coming and for the great questions. Good luck to everyone.
Thank you.